The next is the hip examination. So would you be able to lay on the bed for me, please? So since the patient did not complain of any pain, we're just going to skip to hip range of motion. So now we're going to do the flexion. Kai, would you be able to lift your leg for me? Okay, so that's the flexion, and then the other side, please. On your left side, sorry, on your right side again. Left side, okay, good. So now I want you to lay on your belly. Okay, and then do an extension. Wait, no, sorry. Just like that. Extension, and then do the other side. Extension. Okay, and then now I want you to go on your side. We're gonna do the abduction and adduction. Okay, so abduction and then adduction. Okay, adduction. Okay, abduction and adduction. Do it the other side. Can you face me? So adduction and abduction. Okay, adduction and abduction. So it's easier when we probably like have the patient lay on his back, and just with this one I would abduct it. Okay, guys. So adduction and abduction. Adduction and abduction. Okay, do the other side. And abduction. Okay, good job. The next step is observation. So with the range of motion, after the observation is the range of after the observation and range of motion is we're going to do a palpation of the area. So palpate the hips starting with the interior surfaces. So I can feel the ASIS or the anterior superior iliac spine, and have the patient roll slightly. And you can feel the greater, so I will have to palpate the ASIS first. So this is the ASIS, the anterior superior iliac spine, and it's the same in this side. Okay, so can I have you face over there, and with the camera, like this is the greater trochanter. You can go on this, greater trochanter, and this is the ischial tuberosity, and along on this midline is what we call the sciatica nerve. So when you're palpating on this side, just be a little bit light with palpating it, because some patient has some discomfort, especially if they have an issue with the sciatica nerve. Yeah, and then it's the same thing with the other side. Okay, face on this other side, and we will show them the. So again, this is the greater trochanter, and then this is the ischial tuberosity, and along that side is the sciatica. Okay, thank you. So so then the sciatica notch in between those areas, the SI joints, the thicker iliac joints are the base of the spine at the superior of the buttocks area. There are little dimples that we see that you might see in the surfers or when someone is wearing a swimsuit. It is pretty easy to see, because those are like two little dimples on this side. Okay, so the next is what we call the straight leg test. So this is a test that you would perform if the patient is complaining of back pain. So it can be radiating down on one leg, and you are if you're suspicious for sciatica or herniated disc, with the patient in supine, you ask him to raise his leg as high as he can, and you can help him if he needs some help. If there is pain and discomfort when the leg is extended much, if there is pain at any time, you know what degree of the pain. Of course, if it's below 45 degrees, that is a positive straight leg test, and suspicious for sciatica or herniated disc. if the pain is right shooting down the right leg, you can also do the same with the opposite or the unaffected leg. But first, let's do the raised leg test. Okay, can you raise this leg? Okay, and then the other side, please. Okay, so the next one that we're gonna do is what we call the positive cross straight leg raise test. So if I have the patient raise the unaffected leg, then he feels pain on the affected leg. So Kai, can you please raise this side, please? So the patient will probably feel pain on the affected leg while he's raising the unaffected leg. And it's the same thing at the other side. If this is the unaffected leg and this is the affected leg, if he raised this leg, he feels the pain on that unaffected leg. So that is what we call the positive cross straight leg test. Okay, so next is we're gonna do the knee examination. So Kai, I will have you sit. I will have you stand up, and then we will do the positive neck. We'll do the knee assessment. Okay. So can I have you sit down on here, Kai? So the knee test. So I will have the patient sit down, but she's now sitting down, and have knees over his side. So I will start with inspection and assessment of the patient's knee, looking for this again for symmetry from one knee to the next, looking for any obvious effusion. And then also I will be looking for redness, swelling of the knee, which could indicate an infection, inflammation, and even trauma to the joint. And then I will palpate the knee. It might be easier in the medial surfaces knee where the femur comes down. So this is the knee. So this is the knee, and these are the median side, and this is the lateral side. So there is a little groove underneath the patella. So this is the patella, and then there is a little groove in here. Okay. So actually, the patella is actually kind of like it frames the knee. So this is the frame here and here, and this is the lateral and the medial side. It's medial side. So so they kind of like frame the knee cup. So medial side, lateral side frame that frames the knee cup. Obviously, the patella there is in the center. So this is the patella. So there is a little groove here, which is the tibial tuberosity. This is also the site that gets really pronounced in people with Osgood shallots, and it becomes large. So it's like a bump in here that you can actually you can notice right away because it's like a large bump. So so you would assume that if you see that, then the patient probably had a Osgood-Schlatter's disease disorder. So they will generally tell you that yes, they had a history of it. So the patella is framed by the medial and the lateral epicondyle of the femur, the condyles of the fibula here, in between the condyle and the epicondyle on each side of the meniscal groove. So you have your lateral meniscal groove right and the meniscal groove on the opposite side. In between the groove sits the meniscus of the knee, where there are some kind of like, that's what we call the shock absorbers of the knee. So yeah, so it can indicate a possible meniscal tear if the if there is meniscal damage or injury on the posterior aspect of the knee. So Kai, can you please stand up, please, and face the wall, please? Okay, face the wall. Okay. So with the back area of the knee, so in the back area, which is on this side, if you see like a ball, like there is like a you can palpate like a ball texture at the back of the knee. That is what we call the Baker's cyst. So it's usually like patient will have like a lot of like discomfort if you ask them to do squatting, because like it kind of like press on the Baker's cyst. So I will have the patient sit again for the range of motion of the knee through the flexion and extension. So extend the knee and flex it back. So extend, 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 and extend and then flex. Extend and then flex, flex, flex. Extend and then flex. Okay? And then again, extend and flex, and then the adduction and the abduction with a B again is away. So adduction and abduction. So open your face. Abduction and adduction. So abduction and adduction. Okay. So those are the range of motion for your knee. So there are a few special tests that we can do that involves the knee. Okay. So if you can lay down again. So we're gonna do the Varus test. So with the Varus test, so this is like what we can like check for like meniscal damage. So for the first one of the Varus testing, you're going to be stressing the lateral aspect. Place your hand on the patient's knee, on the inner part aspect of the knee, and then with your other hand on the lateral aspect of the ankle. In this, with your hand, and then you will apply the pressure medially. So here in the ankle, and then your other hand will be on this side, and we're gonna do the Varus test. So, okay. So I'm gonna do this. So that's the Varus test. So it's the same with the other side. Your hand is here in the medial, and then one in the outside, and you will put a little pressure on there. And then next is we're gonna do the vagus test. Did you see the one of the vagus test? So it's the opposite way. So it's the lateral. So you're gonna be pressing the lateral area instead of the medial area. So and then you're gonna switch on the side. So that's gonna be called the valgus test. So your hand will be on this side, and then the other hand will be on this medial side of your ankle, and then you will press it like laterally. So it's the same thing with the other side. So you're gonna press it laterally. Okay. So the next test will be so if there's any discomfort, then yes, there is that's a positive Varus and a valgus stress test. Okay, so the next test is going to be the ACL and the PCL. Which are common injuries that can be sustained in the sports, and the complaints of which has complaints of the knee pain. So you have to keep the patient's leg stable, so it's not going to move the leg. With the palm of your fingers, place your hand behind the patient's leg and kind of a fossa where you would check for a bigger cyst, just distal to that. Then place your thumb on the condyle of the tibia and fibula and try to slide the tibia and the fibula toward you like a drawer. So it is called what we call the anterior drawer spine. So you would apply pressure on that side. So normally you can just like probably like you can do it like by just like okay, let me just, so you can do it by here, okay. So bend this. So you can just sit on that patient thing, and you will like put pressure like a drawer on that side. So yeah, you'll put like a little pressure on that side. And then the other, so on that side, and the same thing with the other side. So you just sit on that side, and then you will put like pressure on that side. Okay, so that will, like, if the patient is complain of pain and discomfort, then that is a positive injury on the ACL and the ACL injury. So another test is the test for the medial meniscus and the injuries, and with the knee extended. Yeah, so with the knee extended. So that's the positive drawer sign. So sorry. So the next test for the ACL injuries will call what we call the Lachman's test. It is similar to the anterior drawer sign, except that do not the torque of the body. When you applying it, you would like extend or put one hand proximal of the tibia, and then you would just put pressure on it, and then you will push it down. Okay, so like what we do, what I did. So just a correction for the posterior drawer sign. When you put your hand or your thumbs on that finger, you're kind of like lifting it, and then you kind of like a drawer. Like a drawer, you'll slip it down, and then with the Lachman test is you will push on it, and then if there's laxity, then that's a positive for ACL or ACL injury. So another test is for the medial meniscus or injuries that if the knees are extended. So put the valgus pressure with your hand, pressing in and hyperextending the aspect of your knee. Apply the valgus pressure and just in the right hand cup over the heel, and then internally and externally rotating it gently, and apply the valgus pressure, and then extend the knee. And you can do a couple of times. Apply the pressure with your left hand, with your right hand. Okay, so it's just kind of like this. So you're just gonna scoop it. You're just gonna scoop it here, and I'm here. So you can like actually focus on this side, and then you're gonna extend, and then you can. And it's the same on that side. You can just like, you have to scoop your hands on there, and then just okay. So that's what we call the positive. Like he would like complain of discomfort on that side. So the next two tests of the knee effusion are what we call different ways to do this. There are a couple of different things that you can learn to do that, and the easiest one is called the ballotment. So just take the patella, and press down sharply and quickly. See if there is any fluid that will be displaced either laterally or medially. So with the patella, you kind of just like, press on it sharply, and then it's the fluid will either like go laterally or medially. So it's the same on the other side. You're either going to press it sharply, and then fluid will go either laterally or medially. So it kind of like it looks like a balloon, a balloon. You should see there if there's an effusion or fluid, the ballooning over the medial aspect. Alternatively, sharply press on there, and then you with your left hand in the medial compartment, you can sometimes feel the fluid wave as it hits the other hand. But many times, a knee effusion is fairly obvious symptom of the fairly obvious sign when you are at the patient's knee, and know that he has no effusion. So it's more like an observation and inspection skill than it is like a technical skill. So the last test is the patellofemoral syndrome. Patellofemoral syndrome. So have the patient relax his legs as you manipulate the patellar side. as you manipulate the patellar side, it should be really mobile and it should be able to move easily. So take the patella and compress the femur. And then all you have to do is have the patient activate his quad or strengthen his quadricep muscle. And then the patella should track naturally, placed without any pain. So Kai, if I do this, activate this muscle. Okay, do this again, activate this muscle. Yeah, just activate it, just strengthen it, just like tighten it. There you go. Okay. So that is so you should naturally like place it without any pain and any crepitus. Any of the crunching sensation or crepitus, one of the signs whenever you put the joint through the range of motion, you should be feeling for the crepitus in the shoulder, in the wrist, in the elbow, or any grinding or grating sensation. You know, from when a bone and a cartilage like friction underneath, you are feeling for crepitus, and the knee feeling like there's crepitus in the knee, feeling for crepitus in all the joints. So the next one will be the feet. So the next thing will be the feet, and the ankles. So it's the same thing for the feet and ankles. And you wanted to look for any deformities, any swelling, any redness, and any warmth on the when you're inspecting it, and then also you wanted to look for symmetry for both of the feet and ankle. So yeah, so and then you might and also you should look for bruising and swelling on both of the foot. So in the great toe, you can see so you can also do you can start doing the palpation. In the great toe, you can see if any joint or any common, like the first great toe, the metatarsal phalangeal joints. Palpate the lateral malleolus and the medial where that sticks out in the lateral aspect of the foot. Palpate the medial, which is a great bone that sticks in the lateral aspect of the foot. Palpate the medial malleolus and the internal aspect of the foot and the calcaneus. Okay, which is the heel bone. This is the heel bone. You can focus it on the foot. Yes, and then you wanted to check the distal interphalangeal, the DIP and the PIP of the toes, feeling for any pain, deformity, holding the arc of the patient's foot with the planters where he is kind of like flat, and that can lead into pain. If there's like something going on with there, he would complain of any pain. So to know that the range of motion of the ankle is just flexion and extension. So and then eversion and eversion. So Kai, can you do a flexion? Sorry, no. Flexion, extension, eversion, and inversion. So do flexion, extension, eversion, and inversion, and eversion. Okay, so so we have the range of motion, and then so the patient can also do like big circles, like they can also like do one of the range of motion for the foot and ankles. They can do Kai, can you do like a big circle and then going around again the other side in all 4 different areas, and then the other side, and then okay. So that concludes our musculoskeletal examination or assessment. Thank you.